Tanto sì, sì, i colleghi entreranno. Allora, io ci tengo moltissimo a dare il benvenuto a tutti quanti a questo seminario. Devo dire che quando Ursula me l'ha proposto, anche se so che magari per alcuni di voi, cioè alcuni di voi hanno già sentito, però penso che in generale il metodo, l'argomento proposto è assolutamente rilevante, interessante, in qualche modo affascinante per le sue implicazioni. Quindi sono molto contenta, ringrazio molto, io ringrazio Ursula e ringrazio Francesco Bernadesi, ma voglio veramente ringraziare tutto il gruppo di lavoro di farmacoepidemiologia dell'Associazione Italiana di Epidemiologia per quanto e quanti contributi stanno dando all'AIE nell'ultimo, diciamo, negli ultimi anni. Ci tengo molto, volevo dare appunto a tutti quanti l'annuncio che stiamo lavorando su un nuovo sito dell'Associazione Italiana di Epidemiologia, che è bello stavolta, che prevede per ogni gruppo di lavoro la possibilità di organizzare lo spazio anche caricando materiali, e poi potrete decidere voi se darlo in libera visione a tutti quanti o soltanto dedicato parte del materiale al vostro gruppo di lavoro. Ci sarà sempre per voi, c'è Davide Pedri del direttivo che appunto vi aiuterà, diciamo, in questo processo. Non rubo tempo perché appunto abbiamo tempo proprio, e abbiamo scelto di essere rilassati. Auspico una grande partecipazione e le domande per approfittare appunto della gentilezza e della competenza dei nostri relatori. Per motivi tecnici per noi più facili vi chiediamo di scrivere la domanda anche quando vi viene in mente durante la presentazione, e poi Francesca e Davide insieme a Ursula le leggeranno ai relatori. E quindi senza rubare tempo passo sicuramente la parola a Ursula, che invece entrerà più nel dettaglio e ci introdurrà ai relatori di oggi. Grazie a nome mio e di tutto il direttivo.
Grazie Carla, buon pomeriggio anche da parte mia. And good afternoon, my name is Ursula Kirchmeier, and together with Francesco Baronadesi, I chair the Pharmacoepi Working Group of the Italian Epidemiological Association. And one of the aims of our working group is to promote the topic of pharmacoepi both within the association, but obviously also outside of the association, for example, by offering educational activities such as today's webinar. So today we have the pleasure and honor to host two distinct colleagues who will speak about methodological considerations for designing pharmacoepidemiological studies in the COVID-19 era. In particular, they will discuss how the pandemic-related disruptions in healthcare utilization may have impacted on the conduct of non-interventional studies designed to characterize the utilization and estimate the effects of medical interventions on health-related outcomes, including obviously possible threats to external and internal validity. So I would now like to welcome Anne Mobley-Butler, who is an assistant professor at Washington University in St. Louis, and Michael Webster-Clark, who is a postdoctoral fellow at McGill University in Canada. Thank you both very much for accepting our invitation. Your talk is certainly not limited to the field of pharmacoepi, but is of interest to many other epidemiological disciplines and will certainly raise questions. So at the end of the talk, we will have time for a Q&A session, and you are all invited to write your questions in the chat. So thank you both, Anne and Michael, the floor is yours.
Okay, thank you so much to you all for this invitation. This is really our honor, and we're glad to be here today. My only regret is that this is on Zoom and we're not in person in Italy with you all today. So we're going to present this talk called Methodological Considerations for Designing Pharmacoepidemiology Studies in the COVID-19 Era. And let's see, I need to figure out how to advance my slides. There we go. And here are our disclosures. So there's no funding provided for this work. Today, as a brief outline, I'll talk about our webinar objectives, give a brief background and rationale, and then I'll talk about characterizing COVID-19 related disruptions to healthcare utilization and highlighting potential threats to study validity. And I'll highlight 5 study design elements and several potential threats to study validity. And I'll do this through the context of a hypothetical study example. And then I'll pass the baton to Dr. Michael Webster-Clark, who will talk about potential design and analytic solutions and their implications. And then we'll finish with a question and answer session. So our objectives are threefold. So first, we want to discuss how pandemic-related disruptions in healthcare utilization may impact the conduct of non-interventional studies with respect to several study design elements, including participant selection, exposure, outcome, and covariate assessment, and accounting for competing risks. The second aim is to highlight the consequences of these changes on the validity of studies conducted using real-world data from the COVID-19 pandemic era. And then our third aim is to propose design and analytic approaches to mitigate bias in studies that use real-world data from the COVID-19 pandemic era. And a common thread throughout this talk is that we'll try to repetitively consider how concerns may be amplified in populations disproportionately impacted by COVID-19. The content of the slides that we present today is drawn from an ISPI-endorsed manuscript that I led and which was published recently in the Journal of Clinical Epidemiology entitled Non-Interventional Studies in the COVID-19 Era, Methodological Considerations for Study Design and Analysis. And today we're really going to just scrape the surface, but I will point you, if you're interested in more information, to this manuscript. So this topic that we're going to talk about today, it extends beyond recent work focused exclusively on using real-world data to study COVID-19 related treatments, so specific treatment exposure. And here are a couple of examples. And it builds upon previous work addressing the use of real-world data to study non-COVID-19 related topics. And I would particularly draw your attention to this letter to the editor at the bottom by Dr. Webster-Clark that was published in Pharmacoepidemiology and Drug Safety early in the pandemic about ways COVID-19 may impact unrelated pharmacoepidemiologic research using routinely collected data. So a bit of background here. I think we all lived through the COVID pandemic. None of this will come as a surprise, but I do think it's helpful for us to think through the impacts of the COVID-19 pandemic and to think about it through the lens of now we're designing epidemiologic studies and what do we need to think about. So we observed early large reductions in healthcare utilization around the globe. You can see that this is the change in the utilization of healthcare services, and there was this dip in the first half of 2020 in healthcare utilization services, and this is data from 81 studies across 20 countries. Some types of care decreased much more than others. On the y-axis, this is the utilization rate of different types of care. Dark blue represents January and February of 2020. Light blue represents March and April of 2020. And you can see that there are these huge decreases, especially for preventive care and elective care, and somewhat for non-elective care, and less so for prescription drug utilization. The pandemic shifted where and how people seek care. So 3 points here. The first, that the COVID-19 pandemic has been associated with changes in the structure of primary care delivery, with the content of telemedicine visits differing from that of office-based encounters. The second point is that telemedicine more commonly is used for established patients and substantially greater delivery of psychiatric or behavioral treatments rather than preventive care. And third, that telemedicine usage has been documented to differ by age, income level, and other demographic characteristics. The literature documents large racial, ethnic, and socioeconomic differences in COVID-19 impact. So this is analysis by the Centers for Disease Control and Prevention in the US, and it demonstrates a higher risk of COVID-19 infection, hospitalization, and death in minority, racial, and ethnic groups. And this literature, or the literature really documents similar disparities across other marginalized groups, and I'll dig into that a little bit later. We observed disruption of seasonal circulation of viruses. This is one example of % of RSV positive PCR tests over a calendar year, and you can see that the 3 blue curves were pre-COVID, this pink curve was 2020, and the black curves are after 2020, and they have not gotten back to normal just yet. During 2020 and 2021, excess mortality was about 2.7 times greater than the official toll. And what that means for us as epidemiologists is that there's a missing data problem related to COVID-19 infection and mortality. And of course, we all lived through COVID-19, and there was not just one exogenous shock, but several, which we need to think about as we're designing studies. So now I'll turn to the main content about characterizing these healthcare utilization disruptions and highlighting threats to validity. And the study design elements that we focus on today include participant selection, exposure, covariate, and outcome assessment, and accounting for competing risks. And we'll talk about potential threats to external and internal validity. So specifically, we consider how changes to participant selection in real-world data studies may affect external validity via generalizability, how changes to exposure, covariate, and outcome assessment may affect internal validity in the forms of confounding bias, information bias, selection bias, and missing data bias, and how failure to account for competing risks and time to event analyses may result in inflation of risk estimates. So today I'll present pandemic-induced considerations relevant to each of these study design elements, as well as highlighting these potential threats to validity. And then Dr. Webster-Clark will then discuss design and analytic approaches to mitigate these biases in epidemiology studies that use data from the COVID-19 pandemic. We'll draw on the following hypothetical studies. So the scientific objective is to estimate the comparative risks of adverse cardiovascular events among older adults initiating different second-line oral medications for type 2 diabetes dispensed from an outpatient pharmacy. And we'll theoretically use a data source that's the CMS Medicare fee-for-service claims data among people with prescription drug coverage. So in the US, we have universal health insurance for those who are 65 years or older, as well as disabled. And of course, that's the Medicare database. And we'll look at the study period from 2018 through 2023. That is before, during, and after the COVID-19 pandemic. So let's start by discussing the impact of the pandemic on participant selection in real-world data studies. You can consider the possible threat to external validity via generalizability. So participant selection, how has the ability to sample the target population changed over time? Well, during the pandemic, identification of a random sample of a target population using real-world data may be challenging due to substantial changes in health-seeking behavior and healthcare utilization patterns. Systematic differences between a target population and the subset of those who sought care through a healthcare encounter from which the study population may be sampled may threaten external validity. Another important consequence of pandemic-related disruptions is their disproportionate effect on specific populations. So, for example, we know that widespread and urgent implementation of telemedicine programs may have disproportionately served well-resourced patients with stable internet access and comfort with technology. And consequently, studies of telemedicine may include a lower proportion of racial ethnic minorities, rural residents, or people experiencing poverty. And so ultimately, the extent of the reduction in generalizability of our study results will be related to the proportion of the eligible population not selected for study. So continuing to talk about participant selection, we have this table here on the left-hand column. We have pandemic-induced considerations, and then on the right-hand side, an example from a hypothetical study. And we'll continue to use this framework as we work through all 5 of the study design elements of interest. And I really want to state here that given the limited time of the talk today, the goal here is really to bring up pandemic-induced considerations. And then Dr. Webster-Clark will present some potential solutions, study design and analytic solutions, but really we're just trying to frame the potential issues. So, okay, the first pandemic-induced consideration that we'll talk about is that due to stay-home orders, patients seeking healthcare encounters may have been more sick or more frail. And an example from a hypothetical study may be that fewer and different patients, perhaps those with more advanced diabetes, sought primary care during the pandemic era, which would result in a study that selected a possibly non-random sample of the target population. And this change may result in a different sample average treatment effect than the average treatment effect in the target population. So we need to think about changes that may have occurred pre-COVID versus during COVID. Our second pandemic-induced consideration, some populations may have been disproportionately impacted by COVID. We've already talked about this. So an example from the hypothetical study would be that during the pandemic era, underserved populations may be less likely to seek care for diabetes, due in part to disproportionately higher either true or perceived COVID risk, and thus they may be less likely to meet study eligibility. Our third pandemic-induced consideration is that we observe changes over time in different patient populations. So we observed increases in the use of telemedicine. We observed in the US an increase in Medicaid insured. So that's the safety net population with a low income. And we observed changes over time in the patient population that was purchasing additional prescription coverage. So as an example, enrollment in Medicare Part D, so that's our prescription drug coverage plan for those 65 and older, may have increased among younger Medicare patients due to the perceived risk of COVID-19, resulting in a different or younger population eligible for study during the COVID years. Okay, I'm going to switch now to the second study design element of interest, which is exposure assessment, and talk about how it may affect study internal validity via confounding bias, information bias, selection bias, and missing data bias. And for the study design element of exposure assessment, we ask whether exposures can be accurately identified using data from the early pandemic. So this figure shows that prescription fills peaked the week after the March 13th, 2020 declaration of a national emergency by the US. And this we can see here is particularly true for the chronic medications as opposed to perhaps azithromycin or amoxicillin, which would be to treat an infection. And thus, researchers worry that stay-home orders resulted in stockpiling of drugs, resulting in limited ability to accurately identify start and stop dates of prescription drugs. So in healthcare database studies and medications, researchers typically identify periods of new use of a drug in the claims database as follows. The start date of the treatment exposure window will be defined based on the dispensing date of the first or second prescription of interest, after requiring a washout period without documentation of drug dispensing. And similarly, drug discontinuation dates are often defined as the dispensing date of the last prescription date, plus the sum of the day's supply and a grace period. So our first pandemic-induced consideration related to exposure assessment is that stay-home orders resulted in stockpiling of drugs, resulting in limited ability to accurately identify start and stop dates of prescription drugs. And an example from a hypothetical study may be that prevalent users who stockpiled anti-diabetic medications may have appeared to have a washout period without a new prescription, resulting in truly prevalent users being misclassified as new users. And our second consideration is that the economic consequences of the pandemic, for example, massive job losses, may have resulted in changes in prescribing patterns and medication adherence as well. So as an example, the higher costs of SGLT2 inhibitors versus sulfonylureas may mean that sulfonylureas use may have increased during the pandemic era relative to SGLT2 inhibitor use, resulting in possible residual confounding by socioeconomic status. And relatedly, adherence may have been worse for the more expensive drugs, SGLT2 inhibitors, also resulting in possible selection bias. Okay, so now I'm going to switch to the third study design element of interest, covariate assessment, and how that may affect internal validity via confounding bias, information bias, and missing data bias. And our first pandemic-induced consideration is that the pandemic-related decreases in healthcare encounters, particularly for certain types of healthcare, like preventive care or elective care, like we showed in that figure earlier, may have resulted in undiagnosed clinical conditions. So an example from a hypothetical study might be that delayed primary care visits may result in misclassification of hypertension in the baseline period, increasing potential residual confounding. So there was the COVID pandemic, somebody delayed their primary care visit, and they were not diagnosed with hypertension. In the pre-COVID era, they would have been. Our second consideration is the shift from in-person encounters to telemedicine visits may have resulted in increased missingness or measurement error of potential confounders, such as clinical measurements and routine lab results. So for example, blood glucose levels measured from home monitors may be less accurate than those measured in the clinic, resulting in increased residual confounding and measurement error. I can give another example that's not related to our hypothetical study. I had a 9-month-old infant during COVID, I think April 2020, and I didn't take him in for his 9-month visit because he wasn't due for a vaccine, but instead did a Zoom visit, and I measured his height or his length, right? And now when I go to the pediatrician, we look at the curve of his height, and we always laugh at my measurement at 9 months was just way off, that kind of thing. A third pandemic-induced consideration would be these new potential confounders or effect measure modifiers of COVID-19 infection history and COVID-19 vaccine status, which often are not well reported. So an example from a hypothetical study would be that COVID-19 infection increases the risk of our outcome of interest, a cardiovascular disease event, making it a potential confounder and or effect measure modifier. So I'll move on to our fourth study design element of interest, outcome assessment, and talk about potential threats to internal validity via information bias, selection bias, and missing data bias. And our first pandemic-induced consideration is potentially incomplete ascertainment of lower severity outcomes that may not have warranted or resulted in a healthcare encounter. For example, patients who had very minor strokes that remained undiagnosed may have resulted in outcome misclassification of cases as non-cases and underestimation of the risk of these outcomes. A second consideration would be that some populations may be disproportionately impacted by COVID-19. And in a hypothetical study, the aforementioned outcome misclassification could be amplified in underserved populations who were less likely to seek care due to higher perceived or real COVID risk. And thus this outcome misclassification may become differential. And differential outcome misclassification, which is differential underdiagnosis by treatment group in this example, may result in bias that either exaggerates or underestimates the risk of the outcome. And then lastly, related to outcome assessment and whether our outcomes can be accurately identified. At least, in the US where we don't have a national health insurance plans, among commercially insured populations, loss of employment may have resulted in loss of health insurance coverage, and often did. And what happens here is that, right, if you're thinking about your data and a patient record, you've got data, they've got health insurance, you're able to follow them up, they lose their job during COVID, they lose their health insurance, and all of a sudden we don't have any data. We have this loss to follow up, we have missing outcomes, we don't know what would have happened to them. So in these hypothetical study, we're talking about studies of commercially insured patients are subject to selection bias due to differential loss to follow-up between treatment groups. And this is also known as informative censoring. So lastly, I will conclude by discussing the impact of using real-world data from the COVID-19 era with a focus on the importance of accounting for competing risks and time to event analyses in order to prevent inflation of risk estimates. And first, COVID-19 caused substantial excess mortality in older adults. And importantly, in our hypothetical study, the excess mortality was even higher among certain subpopulations, including racial ethnic minorities, lower educational attainment, or people living in poverty. And that has been well documented in the literature, of course. And our second consideration is that mortality is a competing event, which precludes the occurrence of many outcomes of interest from occurring. So in a hypothetical study, eligible patients may have experienced mortality, which is our competing event, prior to experiencing an adverse cardiovascular disease event outcome. Right, so they may have gotten hit by a bus, but they would have had a stroke a week later, and they didn't have that, so we didn't see that. And this can result in inflation of risk estimates when competing events are treated as censoring events. But what does that mean? So I think this figure by Brian Lau, published in the study in 2009, is really intuitive, helps us understand this really well. So this figure illustrates the difference in risk sets for two cumulative incidence estimation methods. One simplified method where we censor for competing risks, or two, a method where we actually account for competing risks. So on the y-axis here, we've got risk set at time t for event one. And then on our x-axis, we've got discrete time from 0 to 6. And at time 0, we see that there are 30 black dots that we can imagine represent 30 Medicare patients at risk for developing an event of interest, for us, cardiovascular disease event. And at time 1, we see a square, which represents one person had an outcome of interest, the cardiovascular disease event. The triangle represents one person had the competing event, which is death. At time 2, we see no outcomes of interest, but we see 2 competing events. And at time 3, we see 3 outcomes of interest and 1 competing event, and so on. And in our analytic method, when we don't account for competing risks in the analysis, so when we don't account for these triangles, we treat death as a censoring event, which means that the survival function eliminates these individuals who experience the competing event from the risk set. And then the cumulative incidence estimate can be interpreted as the risk of the cardiovascular disease event in this Medicare population, assuming that all deaths could be prevented, which they can. In contrast, we can treat death as a competing event. And here, the competing risk model specifies that individuals who experience the competing event remain in the risk set for the event of interest. Thus, the risk set includes 2 distinct groups. So the circles, those who have not failed from any cause, and those who have previously failed from a competing event, so the triangles. And therefore, the competing risk approach provides an estimate of the total amount of the outcome of interest or cardiovascular disease events that will occur in the population, and doesn't make the assumption that all deaths could be prevented. The point I really want to make here is if we're estimating the risk of an outcome in a population with low risk of a competing event like death. So let's say we're estimating the risk of some vaccine preventable disease in an infant population, we don't need to worry about accounting for competing risks for the most part, because using these 2 methods will generate very similar risk estimates. But if we're working in a population that has a high risk of our competing event, so for us, we're talking about an older population, so 65 and older, that have a higher risk of death. And now we're talking about this during the COVID-19 era, where we see so much more death occurring in this period of time. So it's really important to be accounting for these competing events in this pandemic era. Okay, so we just talked about all of those study design elements, and I'm going to pass the baton now to Dr. Webster-Clark, who will describe potential design and analytic solutions to address these potential threats to validity related to these study design elements.
Thanks, Anne. Super informative, as always. Can you stop sharing real quickly, and then I can pop in? Okay, just quickly booting it up. I want to give a echo Anne's thank you to everyone. This is a great opportunity, and I'm really excited to talk with everyone here about some of the potential design and analytic solutions, and really critically thinking more about what it means for the estimates we're getting, and how much we should be confident in them, and how much we can kind of treat them as our best guess of a treatment effect, whether it's for a drug or for some environmental exposure or for some sort of disease course epidemiology. So I'm going to start by talking about something that I feel like I talk about in all my talks, but Dr. Butler touched on it a little bit, which is effect measure modification. So in case you're not familiar with this term, sometimes it's called interaction, sometimes it's called effect heterogeneity. But what it is just something that happens when the treatment effect of something you care about X on an outcome Y changes across levels of a third variable L. So if you're talking about a risk difference, it just means that people with L equals 1 have a different risk difference than people with L equals 0. Or if it's a continuous variable, that there's some function in terms of the risk difference that changes across levels of the continuous variable. And like I said, this is sometimes statistical interaction, but in epidemiology, and particularly pharmacoepidemiology, we throw in the effect measure part just to make it clear whether we're talking about a risk difference or a risk ratio or a hazard ratio. And most of the time, as epidemiologists, this is an interesting phenomenon for us to study. It's not a concern, it's not a problem for our estimators or anything. It's just something that you might want to look into in your data to learn something more about the world, about a disease, about an exposure or a treatment. And it's simply studied by separating people by L. So here you have the gray people and the green people, and seeing, oh, this treatment X equals 1 appears to perform differently in people with L equals 1 and L equals 0. Maybe we're going to target people with that are gray for the intervention because it doesn't seem to do anything in people that are green. But what if there's temporary or calendar time EMM? And the example I think of here is the idea of a meteor hitting a community. So this hypothetical community gets flattened by a large rock coming from space. And if we're studying a drug or any sort of exposure, would we want to look at its effect during the time while the meteor strike was happening and its immediate aftermath? Is that what's interesting to us in public health? And also, would we like to know about this treatment effect before or after it was flattened? And these are kind of different questions. So one of these is asking, if we have some major impact to a system, should we be focusing on studying its effect during that impact? Not. And the second question is, should we be focusing on studying its impact or its effect before or after the impact? And I think usually, and I'll reinforce this at the end, we don't care about the immediate time of the stress, but we do care about the effect after the stress occurred, because that's the world we live in. That's the world we're going to be advocating for interventions in. And this has pretty major implications for the kinds of ways we're going to handle the COVID-19 pandemic era. So this pandemic did create effect measure modification, right? And some of this effect measure modification is sticking with us today. This is things like greater mortality benefits from drugs that treat COVID mortality risk factors. So all those risk factors for COVID, hypertension, diabetes, if those get managed by drugs, those drugs are probably helping more than they did before the pandemic. And since COVID is circulating, they're still helping. There's less benefit of immunosuppressing therapies. This has kind of attenuated as the pandemic has gone on and the strains have become less potent, but it's still there, that it's more dangerous to have a suppressed immune system now than it was before 2020. There's long COVID consequences. Any sort of depression or antidepressant treatment might be more beneficial in the wider population now. And in our example, since long COVID increases CV risk, it would potentially increase any discrepancy between the two treatments in terms of their impact on CVD risk. For temporary modification, there's tons, obviously, that Dr. Butler talked about. So we have later diagnoses of cancers, which leads to less effective cancer treatment and poorer performance of these treatments in terms of absolute benefits. Short mortality increases that act as competing risks and modify the absolute effects of a lot of drugs. mental distress and damage, which obviously changes how people interact with the health system and potentially changes how effective other treatments are. Less effective management of a whole bunch of chronic conditions because people weren't seeing doctors, greater socioeconomic status disparities, and the competing risk of death being especially high prior to the vaccine. So not only is this temporary EMM during the pandemic period, it's temporary EMM that changed over the pandemic period as we started implementing more interventions. And all of these are going to be equally impactful for studies of some drug treatment and for studies of wider exposures and any sort of public health study, because none of this is exclusive to drugs. So what kind of analytic method do we need then? Well, it's a piece of cake. We just need a method that identifies and accounts for pandemic-based and COVID-based misclassification, all those areas Dr. Butler talked about. We need to remove the influence of temporary EMM because we don't want to focus on the time period while the asteroid is hitting. We want to focus on the aftermath. But we also want to make sure our method keeps around the persistent EMM and lets us quantify it and evaluate it. And we also don't want to work too much harder. So obviously this is going to be simple, right? Especially if we want it to have no impact on precision. Well, unfortunately, this isn't really the case. We can't really find anything that does all of this. The simplest solution is administrative censoring, right? And I think all of us have to some extent been doing this in our research to one degree or another, where we find the start of the pandemic, we find the quote end of the pandemic period that we're worried about, and then we just cut out all of that person time. So follow-up for people stops. When we get to that point, we don't let anyone into our cohort. There's a big question about what do we do about the time after the end period? Do we let people into our cohort? Do we readmit people's person time if they made it through? But for the most part, I think people are avoiding that by simply just saying the pandemic start is when their study ends. And so what this does is eliminate this time period from our analytic data completely by prematurely ending follow-up for people when the pandemic starts, not letting people into the cohort during the pandemic, deciding optionally to maybe let people in after the censoring period, requiring some sort of pandemic washout for covariate lookback. As Dr. Butler mentioned, there's covariate misclassification because people aren't going and engaging with the healthcare system. So if we want to get rid of that, then we need to look even farther into the future if we're letting people back in. And we have to make that decision about re-entering the cohort after the censoring period, or allowing people in who became eligible during the censoring period. And using censoring weights gets a bit tricky in this context. So if there is some sort of differential censoring occurring between your treatment groups, it's really hard to get rid of that with censoring weights because the question you end up asking is very, very weird. So as far as measurement error goes, this does get rid of the pandemic-based outcome and exposure measurement error, right? If you get rid of this person time, you're not going to have issues where you're incorrectly classifying people's outcomes or exposures due to pill stockpiling or telemedicine. And you optionally will eliminate the covariate measurement error, whether or not you let people into the cohort after the pandemic and how much cohort look back you require. And this also does avoid temporary EMM resulting from the pandemic, right? This lets you say, oh, we're not going to have to worry about those elevated short-term mortalities that occurred because of the COVID infection and how that changed because of the vaccine. None of that matters to our study. But it also greatly reduces the influence of the persistent EMM created by COVID and the pandemic. So this pushes us to studying what our exposure was doing before the asteroid hit, before the pandemic, which I think has some unfortunate implications. And it really pushes us towards estimating an effect in the past. We're always stuck with estimating effects in the past, but this pushes us even further into the past than some of the other methods that we might be able to employ. So for our example study, we could censor people on March 1st, 2020 and let people back in starting March 1st, 2022, just chop out those 2 years. We don't have to worry about different confounding structures during the epidemic. And we get rid of all that outcome and exposure misclassification, but all those people entering in 2022 still have some covariate misclassification that might make it harder for us to account for confounding or selection bias. And we'll pretty much split our eligible times from pre and post pandemic. And probably to explore that type of persistent modification, we would want to stratify on calendar time to look at whether treatment effects seem similar before and after the pandemic. We might even further want to stratify on previous COVID infection. So this is something we could do while adopting this period censoring approach, where we don't just stop our study completely, we restart our study after some point where we think the influence of the temporary EMM has generally reduced and we're kind of at standard levels that we'll expect for the future. Of course, you can also censor people after COVID diagnosis. So this is going to be particularly relevant, I think, for some environmental studies. But the idea is we know in our data that these people were diagnosed with COVID at these times. We can essentially stop follow-up then and cut them out of our data set then. So specifically saying, okay, we don't want to study people with COVID. And this is a lot like the competing risks question that Dr. Butler talked about, where when we censor people, we're asking what would happen if we could stop this censoring event from happening. So in terms of death as a competing event, it doesn't really make sense to ask this a lot of the time. We can't stop all mortality from happening. But in this case, it might be relevant to ask what would happen with our exposure if we could prevent COVID from happening, because there might be a world where we could either eliminate or drastically curb the impact of COVID when it comes to all of those effect measure modifying factors. And in that case, this can ask some really interesting questions. They're different questions from some of the other approaches, but they're still very interesting. Of course, there's obviously some major limitations to this approach. So first, you have to detect the cases. Oftentimes, we don't do a great job of that in any sort of administrative data source. They weren't really engineered to detect COVID cases, especially early on. You're usually going to need more data, again, because these databases don't really talk to each other, at least in the US. Hopefully, it's better in Europe. And it doesn't really account for those pandemic impacts, right? Because one thing that happened was the virus circulating, but another thing that happened was the societal changes that occurred while the virus was circulating. And those elements are still going to act and change your treatment effect estimate here. So those sorts of temporary EMM don't get accounted for by the censoring mechanism, only the ones that are actually due to the disease and only to the extent you actually have measured data. So if it's because of COVID that this measurement error is happening, you do a great job getting rid of that, but you don't get rid of any of the pandemic measurement error. And it gets rid of that COVID-based modification. To the same extent, it eliminates the COVID-based measurement error, but again, doesn't impact the pandemic-based modification. So the consequences of the lockdowns and everything aren't really going to be addressed by censoring people when they have COVID diagnoses. You're asking a really different question. But it doesn't push you towards the past as much, but it does push you towards this alternate world where we could prevent COVID infection. And that's assuming you're doing it properly. And that's a heavy assumption to make. So we could censor people in our hypothetical study after COVID diagnosis, which would mean that we don't have to worry so much about confounding because of COVID-19 infection or confounding due to COVID. We won't have to account for COVID infection causing misclassification, but we will have to worry about pandemic misclassification, and we'll also have to worry about potential selection bias because we're adding this censoring mechanism, which can result in bias when it's differential. And we end up estimating this effect in COVID-naive people before, during, and after the pandemic. So any of that temporary EMM from the pandemic will impact our overall estimate, like that idea of people starting treatment later, if that modifies the effect on cardiovascular risk, things like that. People delaying treatment for cancer, that's not going to be addressed by censoring people at COVID diagnosis because people were delaying their cancer treatment because of the pandemic, not because of COVID infection. And again, we probably want to look at calendar time. The other thing we can do is zoom in and correct measurement error. And I think this is kind of the gold standard approach we all wish we could do, right? Where we can account for measurement error and restore our data using validation studies or information from other newer studies with some sort of gold standard measurement from the past. And this can apply to anything, confounders, exposures, outcome, anything. But the more corrections you add, the more intensive it gets to implement in a rigorous way. So obviously, this is really great for correcting both COVID-based and pandemic-based measurement error. It's really effective and analytically straightforward for covariates, and then it's more complicated for outcomes, and then it gets even more complicated for treatment. So you have to be worried about how many levels you can really dig into effectively. And it preserves all of the effect measure modifications. So this keeps all of the COVID-based EMM. You're still going to be looking at people who have COVID in your study. And you're also going to be preserving the pandemic-based kind of temporary EMM from those pandemic measures as well, just like when you censor people when they have COVID diagnoses. but it does give you your best chance at evaluating how treatment effects or exposure effects changed over the course of the pandemic, both before and after. In our example study, we could do validation studies for all three of these things with our linked medical records and chart review before, during, and after the pandemic. We'd still need to worry about changes in confounding, but as long as our validation studies were well done, we don't have to worry about the misclassification as much. So our confounding control and censoring weights should perform better in terms of the measured variables. And all of that effect measure modification is going to still be there. So we probably want to explore stratifying patients by COVID infection and time period if we're going to implement this, again, to get at, well, what's the treatment effect now versus what was the treatment effect in 2018? As Dr. Butler mentioned, competing risk censoring means we're assuming we can eliminate competing risks. These other methods like Aylan-Johansson or fine gray incorporate the impact of the treatment on the competing risks. And this is really, really important. I just want to emphasize for estimating risk differences or absolute risks or weights. So there's tons of other types of studies. We use one example here. There's one-time treatments or like long-term exposures, fixed schedule infusions, electronic medical record data, registries, randomized treatment. All of those things have their own kind of unique considerations. So as Dr. Butler mentioned, we're really only scratching the surface here. I'm going to quickly conclude by just reinforcing accounting for the pandemic is not easy. There's no one-size-fits-all approach we can really adopt here. Which of these approaches or other approaches you want to use all depends on how much you care about and the plausibility of changes in treatment effects over time, covariate misclassification, outcome misclassification, exposure misclassification, whether another COVID wave could change things even more. All of those things impact what sorts of methods are most appropriate. And here are just even more things from the paper Dr. Butler mentioned in J. Clin Epi. It's a great paper and covers a lot more issues with threats to validity than what we talked about today. So designing high quality studies that use data from this era, whatever you're studying, is a really complicated process. All the disruptions to healthcare utilization outcomes in people's lives threaten the validity of non-interventional studies and interventional studies as well. And detailed attention to study design and analytic decisions have really real implications for the quality of future studies that use these data. And then I want to close by kind of just reinforcing that as epidemiologists and people in public health, we want to be kind of looking towards the future. This is a futurist painting from what about the world would look like, I think, in 1900 that was painted in the 1820s. So obviously they didn't do a great job forecasting the future, but when it comes to the studies we do, our goal should really be to inform how people are treated now, tomorrow, and the next day. We can't get too hung up on focusing on the past. And so that's the main thing I would be wary of is recognize if COVID has really shifted what the treatment effect actually is now and try to design your study in such a way that you can plausibly examine that. And if you can't, recognize that it may limit the ultimate applicability of the results. So here's a thank you. I think this is Forest Park. All right. I grew up in St. Louis, where Dr. Butler works at WashU, so I went to some Shakespearean plays in this park, but I never got to see it from this high up. So thank you for having us. I unfortunately have to dip out around 10 for a telemedicine appointment, ironically, but happy to answer any questions then, and please shoot us emails if you have other questions. Thanks.
Thank you very much, both Anne and Michael. I think this was a very, very rich and stimulating presentation. Actually, I do so far not see any questions in the chat because I think that people are just overwhelmed by all the information. And I'm sure it will be very useful to have the video on the website to go through it again and stop at some point and go into it deeper. But just one overall comment, I think that the most important thing about looking at, listening to your presentation is the awareness of all the critical issues which come with the COVID era disruptions. And then, as you said, to put it into the context, to see which of these threats are really important for which kind of study. So the system in Italy is different from the US. So some of your things do not really concern us. There may be others, but one question I would like to ask is, how much do you think many of these issues also affect studies in general? For example, if we think about seasonal variations, flu or something. So how much do you think that is this only stronger in the COVID era, or so are the same issues important in all the studies?
That's a great question. I know you need to leave, Michael, so if you want to try and tackle that first.
Yeah. I think it is very much a data dependent. I think that I kind of use the PICOTS approach in the letter that's to PDS and kind of says, okay, it's about your population. What changed in your population with COVID? What changed for your exposure? What changed for your outcome? What changed for your covariates? And unfortunately, there is no perfect solution. I think actually flu is such an interesting one because that's one where I think it would be hard to argue that the effect of actual like flu infection didn't change during the COVID pandemic, right? Because there were so many fewer cases. And because of that, maybe the effect stayed the same in terms of mortality, but I actually haven't dug too much into that. But I think there's a lot of cases where things did return to normal, and there's a lot of cases where things haven't returned to normal, and there's a lot of things where impacts are delayed quite a bit over time. So in particular, the one I think of is the cancer screening, where yes, it's true that cancer screening has picked back up, but if you're going to study cancer screening, you have to bake in like probably a 6 or 7 month lag to think about what kinds of effects this is going to have on community cancer rates or other elements where you just see, oh, it looks like in the middle of 2020, all of a sudden, none of these exposures caused cancer anymore. And it's like, well, that's because nobody was being screened for cancer. So I think, honestly, the outcome is probably the thing I would focus on the most if I had to pick one thing to think about, because it can really give you the wrong idea about your treatment effect or even just your absolute risks due to how weird things were during COVID.
Yeah, that's a great question and a great answer too. I'm just sitting here thinking about my personal experiences with the studies that I've done post-COVID, where I do some flu vaccine effectiveness, and we just had to skip the 2020-2021 season because there weren't enough cases to even be able to estimate that well. And then other studies that might have antibiotic utilization as an outcome, where people are, of course they were on lockdown for the first part of the first year, but we've really, I think, gotten back to normal in terms of amount of antibiotics that we're prescribing. So I think Ursula, I think it just really depends so much on what we're studying, and that we sort of all have to ask ourselves these questions with every new study that we design. Can we ascertain our exposure well, our covariates well, our outcome well? Are we actually able to identify the study population that we were able to identify pre-COVID? And if not, what has changed? I think we just have to now ask ourselves these questions.
Thank you. Are there questions from the participants? You can open your mic if you want to speak.
I have a question. I'm Francesco. Very nice presentation. It is about something that maybe you slightly touched. I'm not sure. I think it's quite different. Sometimes you are interested in the effect, for example, of a medication during the pandemic. Sometimes in some other kind of studies, instead, you are interested to the effect of a medication or a possible side effect in general. So in some way, the pandemic is a sort of additional problem more than the objective of your research. I was wondering whether in some way this could guide you to different strategies, especially, for example, regarding the problem of competing risk. So whether, for example, a normal censoring would be in some way more acceptable in the case you want to try to evaluate a sort of more universal effect compared to what happened during the COVID pandemic or not. What do you think about this?
Yeah, I'm going to quickly answer before I drop off. I think it's really great to articulate the question you're asking like that, and I think it's really important. I actually, if you are asking that kind of universal question and you don't think the consequences of the pandemic that are longer lasting have changed things, I think the censoring, I think it's perfectly defensible, unless you absolutely need that COVID era data. If you think that things haven't changed that much and you have a strong justification for it, I think it's a good strategy. There's ways to investigate that actually that are pretty interesting. So to kind of look into the pandemic data, put it in the context of the potential errors you can have and say, okay, maybe we use some of the pandemic era, but we set aside our other data to be our kind of core analysis. I think there's some interesting things to do there for these kind of more general questions. The only thing I would just be cautious of is, like I mentioned, focusing too much on the past, because it's very tempting for us to believe that the easiest solution is going to be the best one. There's a lot of cognitive pressure there. I should know I'm working on a study where we kind of are having some conflicts about that. So I totally think that if you have an articulate causal question, it's totally reasonable. Just make sure that you're coming from a good place. And sorry for dropping off. And I'm sure Dr. Butler did a great job with all your questions. So thank you so much for having me, everyone.
Thank you for being here. And yeah, we will keep in touch. Have a good day.
Bye. Ciao. Sorry, that's only Italian.
Yeah, I'm going to piggyback on, that's a great question. I just want to piggyback on that and just say that I mean, we didn't dive into that very much, but it's very much something I've been thinking about, that if we're trying to ask a causal question, you know, what's the causal effect of X on Y, then I think it's really fine to just censor pre-pandemic, because we're still able to answer the question well, and I think so much has returned to normal. But I think it just depends on your question. And it's just something we have to ask ourselves every time we design a new study.
One question regarding the censoring for COVID infection. For example, in Italy, at a certain point, almost everybody had been infected. So your population would be reduced to a very, very selected population, and it doesn't make sense then to study the effect only in those people not affected. What do you think about that?
I agree 100%. And then also, how well is COVID-19 infection really captured in the data, right? We didn't have enough tests at first. Now we've kind of moved on to, some people are choosing not to test so that they don't have to isolate, stay home from work for 10 days or keep their kids home from school for 10 days or, you know, for whatever reason. I think that people are not testing the same way that they were a year ago. And so I think it just doesn't show up in the medical record, and there's only so much we can do.
Are there other questions? In case there are not, I'm sure, and that questions may come up when people go through your presentation again. So maybe you will receive some emails or something, and I'm sure that this topic will be touched in future occasions, also in future conferences, because this is surely something just accompanying us in these years. Because now, if we start using these data, because in several studies these data are really fundamental, this will be one of the topics we need to consider. So very many thanks to you. And Carla, you want to say a closing remark? You don't want to do any closing remarks. So we also thank the Italian Epidemiological Association for hosting this webinar, the colleagues who did the technical walk, and I wish you all a wonderful afternoon.
All right, well, thank you so much. And also, I'm happy to make the slides available or that paper available if that's useful. I can send you
Yes,
an email in case
thanks.
you
That
want
would
to
be
share.
really nice. Yeah.
Sounds
Thanks.
good. Thank you so much.
much.
My pleasure.
Bye-bye.